Good afternoon, everyone. It's so wonderful to be here in person with a room full of people and with even more watching on the live stream. I'm Lloyd, Dean of the Stanford School of Medicine, and it's been amazing to see this department come together. Doug mentioned a little bit about the history, but let me just give a brief synopsis. I've now been Dean of Medicine at Stanford for 10 years. It's hard to believe, it's flown by. And when I arrived, we had amazing epidemiologists, health policy experts, statisticians, and they were loosely grouped into a department known as the Department of Health Research and Policy. And yet there was a much broader group of people doing incredible scholarship, including Doug and his colleagues in the Center for Primary Care and Outcomes Research, which was a part of the Department of Medicine. And there were also people doing biostatistics and bioinformatics in other departments. And it was clear that we didn't quite have the right organizational structure. Now, none of us here at Stanford in particular, myself included, get hung up on organizational structure. The structure should follow function. In other words, you should have the organizational structure that enables people to do their very best work and to do it in a collaborative way. But it was clear that this structure wasn't quite getting there. And in particular, the first group that really wanted a departmental umbrella were the people in biomedical data science. And look, quantitation is heart and core to what Stanford is. And we had one of the, if not the first, bioinformatics PhD programs in the United States, dating back now well over 3 decades, which was an interdisciplinary program, meaning it didn't have an individual departmental home. And we had a desire to build and grow faculty in biostats, bioinformatics. So we created a department of biomedical data science. That department is thriving. It's recruited some absolutely amazing young people into the department, as well as provided a home and an umbrella for a group of people that had been in other departments around the School of Medicine and the university. And then the next department to be formed or sort of reshaped was the Department of Epidemiology and Population Health. Again, recognizing that Stanford does not have a school of public health. Epidemiology is core to, certainly we believe that before COVID. If we had any doubt before COVID, that doubt was removed because of COVID. Epidemiology and population health are core to the scholarship we need to be doing to provide the very best health to individuals and to populations. So we created the Department of Epidemiology and Population Health. And now, with the creation and the launching of the Department of Health Policy, which, as Doug said, officially occurred on September 1st of last year, I think we have the structures that enable the faculty and the students and the trainees to do the very best work in the collaborative way that so typifies and characterizes Stanford. And I'm grateful to the many, many people in this room watching the live stream and others that spent a lot of time thinking about what would be distinctive in the field of health policy and distinctive at Stanford in the creation of this Department of Health Policy within the School of Medicine. And in the end, it was the vision, the compelling vision that they came up with, and the endorsement of that vision by literally every single other school in the university that carried the day in the various processes, culminating with the Board of Trustees in the creation of this new department. And I want to thank Doug Owens for being the inaugural chair. Doug, of course, is a distinguished health policy expert, has been instrumental in analyzing from a very rigorous and quantitative point of view the efficacy and the applicability of various prevention screening mechanisms in our delivery system. And one of the themes I think that has been and is so compelling to me about the department is So much of what we do in medicine and healthcare today is based upon scant, paltry, in some cases non-existent evidence. And we do incredibly rigorous research that led to, for example, from the publishing of the sequence of the SARS-CoV-2 virus to FDA EUA for first-in-class RNA vaccines in 11 months. And the backbone of fundamental discovery research upon which that unprecedented speed in vaccine development was carried out, all of that was based upon very rigorous analysis and detailed, outstanding science. There's no reason why we can't, and we certainly should be, and we are, with our department and so many other collaborating departments at Stanford and around the country, doing the same sort of rigorous analysis of the healthcare we deliver. And that analysis then will inform the policies that others will make and hopefully implement to improve the value in our healthcare delivery system. So that's a little bit about the history behind the Department of Health Policy, and Doug, as he described in the video, its very close relationship with the Center for Health Policy in the Freeman Spogli Institute. Now, let me just say a few words about today's topic for this symposium, and that is the topic of health equity. A sad characteristic of health and healthcare in the United States is that it is challenged from the standpoint of equitable access and equitable delivery of care. We have, for those of us who can benefit and access it, the best sick care system in the world, unquestionably, with new fundamental advances in therapeutics for advanced acute and chronic diseases coming online every day. And yet, access to those services and to those cutting-edge therapies is incomplete and inconsistent across our country, and in particular, across different socioeconomic groups within our country. We knew that. We had firm evidence of that before COVID, but that stark reality became even more tragically apparent during COVID, and still to this day. And in a country that spends now close to 20% of gross domestic product on healthcare, we simply have to do better at providing access to that care and about ensuring that that care can be provided to anyone who needs it. Even more fundamentally, though, we have to provide the type of analysis and access to prevention and to confronting the other factors in addition to the health care we provide that are determinants of health. We've known for years that roughly, it depends upon the study, but roughly 70% of the determinants of health are social, behavioral, and environmental determinants of health. Many people in this room, Dr. Lisa Adams, many others have done pioneering research that establishes that beyond any doubt. Genetics and the medical care we receive account for maybe 20 to 30% of overall health outcomes. And yet, the amount of attention we focus, both in research and in resources in our delivery system, to prediction and prevention, the amount of attention that we focus to addressing the social, behavioral, and environmental determinants of health is far, far less than what we have devoted to developing the world's greatest sick care system. And I think the Department of Health Policy has a fundamental and incredibly important role at addressing these social and behavioral and environmental determinants from the standpoint of the scholarship of understanding what can be done, how do we re-envision our healthcare delivery system, and how can we create a more equitable healthcare environment in our country through the scholarship, through the training that's provided in this department. I know that's going to be illuminated this afternoon in the talks and in the work that you'll hear about. And certainly it's on the minds of Doug and all the colleagues in the department as they plan for a very exciting future for how this department is going to have impact in truly transformative ways. One of the things that I think is so distinctive about the department is the way it already is integrated within the broader Stanford ecosystem. And that truly is the secret sauce about being at Stanford, is that we don't have silos. We try to keep any boundaries or barriers between and among disciplines, between and among schools, as low as possible. We try to recruit great people, great faculty, great students, and then enable them to do their very best work in a collegial and collaborative environment. And that's what it's going to take to have the impact that we know we need to have in these vexing problems related to health equity. So thank you again for being here this afternoon. It's now my pleasure to invite Dr. Terrance Mayes, Associate Dean for Strategy, Equity, and Inclusion, to share his vision for health equity at Stanford. Terrance?
Thank you, Dean Miner. And good afternoon, everyone. It's great to be here with you to share just a few words on not my vision, but Stanford Medicine's role in the future of health equity. But before I do that, I would also like to thank Doug Owens for his leadership and the faculty, staff, and students and trainees in the Department of Health Policy and across Stanford who work every day to advance health equity, to advance diversity, equity, and inclusion. In 2012, I joined Stanford Medicine as one of the DEI leaders here. In 2017, I left to pursue another opportunity, a brief stint that we don't talk about much. But in 2020, I made the decision to return. And I made the decision to return to Stanford because I firmly believe that Stanford Medicine is uniquely positioned to lead on health equity, to make a difference not only on a national stage, but within our community and the neighborhoods that surround us. After the horrific murder of George Floyd, I, like probably many of you, made a personal commitment to do social justice and health equity work with authenticity and in a way that would move the needle. I returned here to Stanford following a pledge made by Dean Miner and hospital CEOs David Entwistle and Paul King. And the pledge came on the heels of George Floyd's murder. And the pledge was simple. It said, Stanford Medicine will not be silent, and we will use our influence to build change, the change that we believe in. Enough is enough, they declared. And it was a promise made on behalf of the Stanford Medicine community that we will be part of the solution for creating a better society, a healthier and a more equitable society. And so following this pledge, Stanford Medicine launched the Commission on Justice and Equity. Hopefully many of you have heard about it and read about its work. The commission had a twofold charge to develop recommendations around creating a more equitable and inclusive Stanford Medicine community, as well as a strategy for establishing Stanford Medicine as a national leader for issues related to health equity and addressing racism as a public health crisis. Last year, the commission issued a set of bold recommendations that provide a holistic and enterprise-wide approach to dismantling structural racism, advancing diversity, equity, and inclusion, and addressing health disparities. These recommendations have shaped our vision around health equity, so that health equity is part of Stanford Medicine's core mission. And doing so by adding a health equity lens to all levels of decision-making here at Stanford, by ensuring culturally informed and equitable care across our health system, and doing so with informed data and standards. And by expanding and building trust in local communities, particularly local communities of color, and doing so through funded partnerships, through scholarships, and also first by simply listening. You will hear more today and in the days ahead about some of the important health equity work, health equity initiatives here at Stanford and at Stanford Medicine. Work that has come since and also well before the Commission on Justice and Equity. And I encourage you to learn more about these efforts and also to get involved. I also encourage you to read the Commission report, which has been made publicly available online. I am encouraged by seeing all of you today, knowing that this is our collective work, that we are in this together. You know, there's an African proverb that says, if you want to walk fast, walk alone, right? If you want to walk further, walk with others. And I want us to imagine a nation in which health outcomes are not determined by a zip code. Imagine healthcare that treats every single patient with the dignity and the respect that their humanity calls for. This is our time. This is the time, I firmly believe, to reimagine our health equity and our justice, equity, diversity, and inclusion efforts, to reimagine them and deliver them with creativity, with ingenuity, and with humility. Thank you. And now it is my pleasure to introduce your next speaker. Dr. Elise Adams is the inaugural Stanford Medicine Innovation Professor and Associate Chair for Health Equity and Community Engagement in the Department of Health Policy. Dr. Adams' research seeks to inform health system and policy-level solutions to promote equitable chronic disease treatment outcomes among older adults with multiple chronic conditions. Dr. Adams has been an incredible leader for health equity here at Stanford and an amazing colleague and friend, by the way. She will chair the next session on social policy strategies for addressing structural determinants of health. Welcome, Elise.
Thank you so much, Terrance, for that kind introduction. Again, my name is Elise Adams. I have the honor and pleasure of being Professor of Health Policy here at Stanford in our Department of Health Policy. And I am particularly honored to be here moderating this particular panel regarding social policy strategies for addressing structural determinants of health. In the Department of Health Policy and in Stanford Medicine, we are committed to improving health equity. As a field, health policy has traditionally focused on access to care and quality of care as modifiable targets of intervention. However, as Dean Miner pointed out, the COVID pandemic was a wake-up call. It magnified the underlying systematic and structural factors that are the fundamental drivers of persistent disparities. Moving toward a more equitable future will require multidisciplinary approaches to understanding factors both within and outside of the healthcare system that drive these disparities. The first 4 presenters today have been specifically selected because of their innovative and impactful work in this area. We're going to have I'm going to give a brief presentation of the individuals. They will give their presentations, and then we'll open it up for questions and answers. I just want to remind everyone, there's a QR code on your tables. Please do scan that, and go ahead and submit your questions that way, and we'll take them on the tablet. So without any further ado, first I want to introduce my colleague, Dr. Jeremy Goldhaber-Fiebert. He is a professor of health policy, a core faculty member at the Center for Health Policy and the Department of Health Policy, and a faculty affiliate of the Stanford Center on Longevity, as well as the Stanford Center for International Development. His research focuses on complex policy decisions surrounding the prevention and management of increasingly common chronic diseases and the life course impact of exposure to their risk factors. Today, he will share COVID-19 lessons about health disparities and advancing health equity. Next to him, I'm pleased to have Dr. Gilbert Gonzalez. He came to us from Vanderbilt just to be here today. He is an assistant professor at the Center for Medicine, Health, and Society, the Program for Public Policy Studies, and the Department of Health Policy at Vanderbilt. Professor Gonzalez's research examines how public policies affect health outcomes, access to care, and health disparities for lesbian, gay, bisexual, and transgender populations. He also studies the role of healthcare reforms on vulnerable populations. And last but not least, my colleague, Dr. Adrian Sabetti, who is an assistant professor in the Department of Health Policy here at Stanford. Dr. Sabetti's research focuses on healthcare and social determinants of health. She will discuss key challenges and policy options for improving insurance coverage and access to care for immigrant populations. Please welcome all the panel to the stage.
All right, I get the honor of being the first one to speak to you on this panel, and so thank you for having me. Let's see. So I'm going to talk about some lessons from COVID-19 and how maybe they can start to generalize as we think about health disparities and advancing equity. I get to speak on behalf of a large team, which I've had the honor to be a part of, that includes faculty members here at Stanford, both within our department and beyond, and also with a variety of really incredibly talented and dedicated trainees and staff. So the errors will be mine, but the credit goes to the group. Let's start out with some death rates that were occurring early on in the COVID-19 pandemic. What we see in this graph for two different age groups shown on the rows are the death rates by HPI quartile, Healthy People Index quartile. So the red bars are the most deprived of the HPI quartiles, and the purple bars on the right are the least deprived. And what we see is that there is a gradient within a race ethnic group of death rates going up for more deprived quartiles. And we also see that some of the minority race ethnic groups represented in this graph have higher rates than people who are non-Hispanic white living in the same quartile. Right? So there's some component that is socioeconomic and structural as reflected by the quartiles, and then some additional piece that's reflected by race, ethnicity, and the things that are correlated with it. The graph on the bottom shows test positivity rates by race ethnicity across small sub-county geographic areas. And what we see is that the test positivity rates in this earlier part of the pandemic were strikingly higher amongst the Latino, Latinx, Hispanic groups of individuals, and that this was highly correlated with the fraction who had sort of high household exposure risk, which means that they were living in multi-generational homes with fewer rooms than people in those homes, and had at least one worker who's an essential worker and presumably was working outside of the home in person during the early part of the pandemic. So we started doing some work as vaccines rolled out, and there was real hope of sort of kind of reversing these early trends. And what we started to see was that there were important disparities in vaccine uptake across race ethnic groups. And so we did some modeling in collaboration with our California Department of Public Health partners, looking at what would happen if both sort of any, quote, hesitancy were addressed, but also some of the structural barriers were addressed as well, suggesting that we could greatly reduce the disparities in vaccine coverage. And as part of those consultations, ultimately, California rolled out a vaccine equity initiative. And one of the things that they did was they targeted essentially twice the number of doses to the low HPI quartiles in the period of time when vaccines were more scarce, with the goal of trying to address some of the barriers to get vaccinated and hence lift these rates. What we can see is, so the vertical dashed line show when that policy was started. And what we can see is that the rise, so the numbers on the top represent the quartile that people are living in, and the colors represent the quartile in which they were getting their vaccination. And what we see is that there's a great rise in the number of people living in the most deprived socioeconomic quartile getting their vaccination in that lower quartile as that policy was put into place. But what we also see is that also increased the number of people getting it in those lowest quartiles vaccination, even if they were living in higher socioeconomic quartiles, as I've sort of indicated with these blue things. So there was some spillover where this targeting, this effort to sort of target and address, it's very difficult to sort of narrowly and tightly target. Didn't happen in this particular case, it appears. However, it's not just getting vaccinated, it's also sort of how difficult it is, the personal cost of getting vaccinated, sort of like Dr. Bibbins-Domingo talked about in terms of the differential cost of participating in trials. So if we look at the one-way transportation time as a metric of this, we can see the bottom line represents the lowest quartile. It's a little hard to see the colors on here, but that's okay. After the allocation policy went into effect, that drive time for people getting vaccinated stayed flat, whereas in all the other quartiles it went up. So, that spillover out of the quartile that was targeted came at some additional kind of private cost to people maybe who were more likely to benefit from it. And there was a benefit of raising the volume of vaccination without sort of raising the costs on people for whom it was hard to bear those costs. So that's some work that's ongoing. I want to talk about a second example. Some work in the California state prison system. So the first is that non-Hispanic Black and Hispanic Latinx people are overrepresented in terms of who's incarcerated in our state prisons. And for some groups, namely non-Hispanic Black, that overrepresentation is enormous. And we can also say that most of the people who are in prison are coming from backgrounds that are socioeconomically deprived in areas that are socioeconomically deprived, just as we were looking at before. And prisons fared terribly, especially in the beginning part of the pandemic, with infection rates and death rates 3x to 5x those of free living communities. So this is an example of that the cumulative risk for people living in dormed housing in prisons during this early part was 60% of people getting infected, and high rates of hospitalization and death, especially in the older groups of incarcerated people. We did some work as the vaccination was early rolled out. California sort of allocated doses towards its prisons. Other states certainly did not. And what was interesting and striking was that the uptake rates, this is sort of an offer, accept, or refuse kind of system, were far lower amongst Black incarcerated people than the sort of overall average or other groups. And this was adjusting for lots of other things as well. But what was heartening and what was important, and this gets back to this sort of historical explanations and what can be done, was among the residents who had initially declined and were subsequently reoffered vaccination, 45, 50% accepted at least one dose. So this is not immutable. There might have been some a greater initial hesitancy, but meeting people where they are, letting them perhaps see others accept, seeing that there's not bad consequences for accepting, ultimately led people to sort of pursue their own best interests of being protected from infection and sequelae. We can see the level of protection that this provided as an example. So in a Delta prison outbreak that occurred in the summer, 15% of incarcerated people tested positive in that prison. And vaccination reduced infection risk, both for naive and those with history of prior infection, and reduced it substantially. And in subsequent work, we've seen this also for Omicron as well. So by going to settings where people are disproportionately represented who are in minoritized or otherwise disadvantaged groups, and by sort of targeting those places for prioritizing the preventive services that are delivered, immense benefit can be achieved, and simultaneously we can be pro-equity in kind of what we do. So that's what I have for you today. Let me hand over to you.
Thank you. Thank you. Let's see. So again, I'm Gilbert Gonzalez, and I'm from Vanderbilt University, where I study LGBTQ health equity and policy. And I want to thank the Department of Health Policy here at Stanford for inviting me. This is really just a fantastic group of faculty and trainees, and I look forward to meeting you all throughout the day. Just a quick plug, I am one of the directors of the Vanderbilt LGBTQ Policy Lab. We have about a dozen faculty working on LGBTQ issues, in addition to postdocs. So if there are any PhD students in the audience looking for a postdoc position in LGBTQ health, feel free to check out our website. I want to start with the policy landscape on LGBTQ Americans. We've won major victories in the past decade. In Obergefell v. Hodges, the U.S. Supreme Court legalized same-sex marriage in every state, including in Tennessee and the other 12 states that were holding out in 2015. I often reflect on the recent changes, and I think that the major victories we've had have been 2 steps forward and more recently 1 step back. When I was born in the 80s, we were at the peak of the HIV epidemic. Same-sex relationships were criminalized until 2003 in Lawrence v. Texas. But we have really made some major victories in a matter of the recent 20, 30 years. One policy that I want to focus on is same-sex marriage and the role it plays on health and access to care for LGBTQ populations. So this slide summarizes what I think are some of the high-quality studies using population-based data sets and quasi-experimental designs. So this gets us at some of the causal impacts of same-sex marriage on health and access to care for LGBTQ populations. So when California first enacted same-sex marriage before they took it away and then granted it back, we saw less psychological distress for LGBTQ Americans in this state. In Massachusetts, once the state legalized same-sex marriage, there were fewer mental health care visits for sexual minority men in the state of Massachusetts. And then in one study I led on New York's Marriage Equality Act, we found that health insurance coverage increased for same-sex couples, especially men in same-sex relationships in the state of New York. And more recently, a Vanderbilt study where we look and take advantage of the timing across all 50 states that eventually enact same-sex marriage. We find that men in same-sex households report more insurance coverage, better insurance coverage, and better access to health care, meaning they're not delaying or foregoing medical care because of financial cost. Just to summarize this, what I read here is that same-sex marriage is not impacting LGBTQ populations equally. Men in same-sex couples tend to benefit, not so much women in same-sex couples in terms of marriage equality. And we are only detecting improvements in health insurance coverage and access to care. From the studies I've seen, and my general takeaway is that we are not consistently finding better health outcomes after same-sex marriage. So marriage equality, it's 1 step towards health equity for LGBTQ populations. But if I think about this as policy, as a prescription, I don't think that dosage is strong enough. And so maybe we need to amp up the dosage or the policy dosage for security for LGBTQ Americans, including non-discrimination protections and the social determinants of health, in housing policy, in education policy, in public accommodations and employment. And unfortunately, the last few years, we've seen a wave of anti-LGBT policies. And here are just a few headlines from the state of Tennessee. Tennessee House passes resolution criticizing same-sex marriage decision. I think we will see some states take steps like they did in abortion and start to say if the Supreme Court overturns Obergefell v. Hodges, same-sex marriage may no longer be legal in these states, including in Tennessee. I imagine more bills will come up like this. Many states have advanced bathroom bills banning transgender and gender minorities from using bathrooms based off their gender identity. In Tennessee, we passed, not me, but our lawmakers passed a new law giving religious protections to therapists. This means that mental health providers and therapists can deny patients based off of their religious views. Frankly, if you are not an LGBTQ affirming mental health provider, you should probably not be treating LGBTQ patients. But I worry that we already face a mental health provider shortage in many parts of the country, including in rural America. And I worry about those LGBTQ people living in rural Tennessee that may not be able to find an LGBTQ affirming provider or a provider that will accept them. And so while reflecting before flying out today, if I had a wish list, this would be some of the recommendations that I would make moving forward. I wish our national health surveys would start asking about discrimination, experiences of interpersonal discrimination based off of your race, ethnicity, sexual orientation, and religion. This would really give us more information about the role that discrimination plays on health and access to care. I'm a survey researcher, so unfortunately, we've seen low response rates in recent years. So we need to combat those lower response rates with bigger data. And lastly, we need to start, I recommend that we trust and lean heavy on our health equity trainees. This generation of PhD students, MPH students, and medical students, they overwhelm me with their passion and their creativity in combating health disparities, and we need to elevate their voices and get them advanced in their careers. But that's all I have. I look forward to the rest of the conversation. If there are any folks interested in LGBTQ health or health policy, happy to chat with you. And if I don't get to catch you during a break or during a poster session, feel free to email me.
Hi, everyone. My name is Adrienne Savity, and I'm an assistant professor in the Department of Health Policy at Stanford. Today, I'm going to talk about immigration policy and health. So I want to start with a snip from ASPE, basically outlining that health insurance coverage and access to care for immigrants is a priority at the federal level. What this report outlines is that there is a form of universal health care in this country. Safety net providers deliver care to individuals regardless of insurance status and documentation status. For instance, Santa Clara Valley Hospital here, or New York City, there's a hospital system called H&H, Health and Hospitals, that is the largest safety net hospital system in the country. For instance, if I'm an undocumented immigrant with an income below 200% of the federal poverty line, and I live in New York City, I can go to an H&H primary care clinic and pay $20 to see a PCP, to get preventive screens, and to talk about my chronic conditions. So this report talks about the safety net system, but it also talks about how individuals are not being effectively connected to the resources that exist. This is because immigrants, and undocumented immigrants in particular, face large barriers to obtaining care. I've just listed 3 here, being access, psychological, and informational barriers. Within access, undocumented immigrants don't qualify for health insurance in most cases in this country. Within psychological, institutional fear, mistrust, and mistrust are widespread, and legal status compounds that. And lastly, informational. This connects back to that ASPE brief, is that these resources do exist. It's just really hard for individuals to get the necessary information about those resources and understand how much it costs. I worked with the Department of Health and Mental Hygiene in New York City, which is one of the preeminent public health departments in the country, to think about one way to do this better. And what we did is we targeted these barriers, access, psychological, and informational, by committing individuals to an initial primary care visit during enrollment, where we sat down with individuals, we looked at a host of clinics that they could seek care at, and asked them where they would like to seek care, and asked if we could make an initial appointment. We sat there, we called the clinic, and we made the appointment. Psychological. We leveraged the existing safety net. This was not creating a new system. This is using the existing resources, exactly what ASPE outlined. That safety net system specializes in caring for this population in many cases. So for instance, in New York City, they have a large Chinese undocumented population, and so we offered one of our clinics was in Chinatown, where providers spoke Chinese. This may create a more supportive environment for these individuals to seek care and interact with a medical system that may be new to them. And lastly, informational. We told individuals they could seek care at these facilities, and we gave them a printout of exactly how much it would cost. A primary care visit would cost $20, a specialty care visit X, ED, Y. This intervention was quite successful. And I want to just be really clear that the key to this was that we had a very strong partnership. DOHMH knows the community incredibly well. They have very deep relationships with community-based organizations that interface with these populations day after day. And they were able to figure out exactly how to craft a system in the context that individuals lived in. It was successful because we increased individuals' use of primary care, which is our primary goal. We diagnosed individuals with new chronic conditions, and we issued preventive screens. In turn, we were able to decrease emergency department visits for primarily visits that were primary care treatable. This intervention was actionable. Again, this really relied on DOHMH. They had the existing connections to take the lessons we learned and incorporate it into the existing safety net. It also was scalable. They knew the government stakeholders, the policymakers, those who were thinking about this issue, and they took the lessons of our RCT to them. As a result, New York has just expanded health insurance to those undocumented immigrants over age 65. And in this next legislative session, they're considering expanding health insurance to all undocumented immigrants. Work like this is critical in informing these policy debates, but in particular, strong partnerships between academics and providers or governments are really important to think deeply about these issues, design these interventions effectively, and then scale them up. I look forward to the discussion.
Thank you so much. Let's thank all of our panelists. Thanks so much. I'm getting lots of questions, so thanks everyone for participating. I think our first question is for Dr. Sabity. So the question is, what are your thoughts on the benefits and risks of insurance providers, public and private, trying to address social determinants of health by connecting members to various services?
Can you say it one more time?
Absolutely. I think the question is really about insurance plans as well as health systems that are trying to identify social needs and then make connections. What are your thoughts on the benefits and risks of that relationship?
So I'm going to interpret connections as connecting to resources in the community. Mm-hmm. So in terms of benefits, I think that's pretty obvious. I'm going to start there. That's the easier one. I think there are clear benefits to connecting people to food kitchens or, someone is SNAP eligible, let's get them on SNAP. I think it's also quite challenging to do in reality, right? Take-up of Medicaid is like in about the 50% number for individuals who are eligible. This is something that I think providers actually do an excellent job of, is when individuals show up to the emergency department and they're eligible for these programs, they will often have them sit down with a community, a case manager to enroll. In New York City and New York State, they have emergency Medicaid that will basically insure individuals temporarily for conditions that are life-threatening. And so that is something actually we did in our program as well, as we pre-enrolled individuals in those services. In terms of risks, I think it's a little more challenging to think about. I personally don't see a clear downside. I think if we're going to talk about an undocumented group, perhaps we want to think about legal status in particular environments where maybe that is like a high-risk interaction. New York City is a sanctuary city. It's very supportive. And so I think really, as policymakers and researchers, we probably need to think critically about what that looks like in settings that are not as supportive for these groups versus settings where it is supportive. And I think we're going to have more risks in the environments that are not necessarily sanctuary cities.
Thanks so much, Adrian. So Jeremy, the next two are for you, so I'm going to combine them for you. The first question is, can you speak about the difference between sort of geographical disparities in COVID testing, vaccine uptake in separate from race? And then as a follow-on to that, a second question is, where are Indigenous people represented in the COVID data?
Yeah, okay. Let me get to the second one first, which is that one of the challenges, certainly with the data in general, and certainly what's been made publicly available, is that either the numbers for sort of lower prevalence minority race ethnic groups are very, very small. So it's hard to make estimates for, say, American Indian, Alaska Native, for example. And similarly, the other thing that happens is kind of some level of ridiculous lumping, like the category Asian, which represents a broad and group of people who have very disparate sort of experiences and risks and exposures and all of that. So, again, it's, researchers always want more and better data. This is one where if there aren't sort of proactive efforts to kind of oversample those populations, they will continue to be sort of underrepresented, lumped together, or excluded from analyses just because there's no power to look at them separately. That's one piece. So we should do better on that for sure. There are strong geographic differences in California and nationally on vaccine uptake rates, on testing rates, on a variety of other kinds of things. So the studies that we were doing were not primarily interested in sort of attributing all of the difference to a particular dimension of sort of people's identity, right? But to sort of think about the combinations that sort of make up their identity and their experience. And that's, I think, also an important part of kind of research that's sort of trying to advance equity, is being nuanced about the fact that people have membership simultaneously in a variety of different ways of thinking about things. So in California, the more rural Central Valley kind of areas going towards kind of the national parks, et cetera, have much lower rates of vaccination even now, much higher rates of hesitancy expressed. That's within race ethnic group across, within those geographies, and lower testing rates, et cetera, et cetera. And some work that we did looking at staff at state prisons, the level of coverage of people in your local community, the community that you're living in, was highly predictive of whether staff who are working at these high risk, for exposure institutions took up vaccination, as did one's cohort of coworkers. That also was predictive. So anyway, so hopefully that answers the question.
Fantastic, thank you so much. So I'm going to throw this next one out to the full group, but I'll start with you, Gilbert, if you don't mind. And that's, I think the question is asking this sort of challenge that we face. We like to think about healthcare as being responsive to individuals' needs. So we think about person-centered care. At the same time, in thinking about health equity, we're thinking about groups. And then when you build on that, to what Jeremy was just saying, is that people are part of multiple groups. Mm-hmm. And so there's some potential tensions there in terms of an area of focus, particularly as we think about health equity. And I'm just curious about if you have thoughts about that particular challenge.
This is a big, hard question.
It is.
I don't know if there's a right answer for this. I think more people are talking about intersectionality in public health and medical training, and people certainly bring multiple identities with them to their clinical experiences, to their healthcare facilities. This is a hard one, and so I don't know how,
Don't look at me.
So in terms of meeting social needs, if there are any clinicians in the room, my advice, I oftentimes try to get more data from our providers. I know you're busy. I know you only have 15, 20 minutes with your patients, but the new ICD-10 codes include what we call Z codes that are measuring the social determinants of health. So if your patient, for instance, is experiencing homelessness or unemployment, you can document that in their record. More health systems are starting to do social needs assessments. I worry that different healthcare systems will use different social need assessment tools and instruments, and they won't be consistent across different hospitals, different facilities. But I think we're doing a better job today documenting and talking about patient social needs than we were 10, 15 years ago. I think some of that is related to the destigmatization of mental health needs, because oftentimes stress and issues within the social determinants of health, they present themselves through anxiety, depression, mood disorders. So I think things are getting better. Yeah, that's kind of where I'm just rambling.
Oh, well done you. That was great. This is wonderful. So Adrian, I think the next question is for you. So the question is, what are the most important policy levers for getting decision makers to enact equitable policies, or if you have any successful pilots of that effort to really change policy and change decision making among policymakers around health equity issues?
Okay, say it again, one more time.
Sorry, I'm gonna do it one more time, sorry.
It sounds like it's for everyone too, I just want to say.
What was the most important lever for getting policy decision makers to enact equitable policies? Do you have any successful pilots of such initiatives?
Well, so I'm an economist, so I would say evidence is the most important. I think it's something that is, it doesn't necessarily discriminate across groups, right? The data is, well, I mean, we can argue against that, but in general, I think creating evidence that supports these policies, that supports these groups, gives policymakers concrete tools and things to implement, things to talk about, things to bring up is really critical. I think also, this isn't exactly what the question asked, but I also think as researchers, our role is to be as timely as possible. I think we tend to be slow, and I think the more timely we can be, the faster we can be, the more nimble we can be, the better able we will be to answer these questions and support.
Wonderful.
Can I chime in? So the other things that I've learned living in Nashville, Tennessee, which is our state capital, and working with policymakers, is that evidence is important, but I wouldn't show up in front of a policymaker with a peer-reviewed study, the 14 pages printed out front and back, but try to condense it. They're busy folks too, and just condensing information and informing them and summarizing issues for them is incredibly important. The other thing that really matters is just personal storytelling and bringing a narrative and lived experience to lawmakers and policymakers, because sometimes those very personal stories can make a big difference, even more so than any peer-reviewed study that I've ever presented with a policymaker.
Absolutely.
So just to add on to that, so oftentimes, but not always, policies will prioritize or target or focus differentially on areas of greater need, whether it's geographic areas or communities or whatnot. And the proposal there is that for a given amount of resources, if there's more need, you can deliver more benefit. And so if you can document that or analyze that, that's sort of very important. The other thing is that sometimes there is a trade-off where you're achieving less population health for more equitable distribution, and making those trade-offs sort of explicit and quantified enables people to say something like, okay, there's a very small drop in overall health gain for an enormous flattening of the inequity curve, and this is worth it. And then they can make that argument to their constituents or as they sort of roll out policy.
Fantastic. So Gilbert, the next one is for you. You mentioned some specific legislation that's going to be necessary beyond marriage equality in order to really see some gains that we're talking about in terms of human rights, quite frankly, for LGBTQ communities. And so the question for you is specifically what types of legislation, you mentioned anti-discrimination policies. Are there other types of policies or even existing legislation that you think would be of importance for people who want to see this change?
Fantastic question, and thanks for asking from whomever this came from in the audience. Yeah, so one example I point to is the Equality Act, which has been passed by the U.S. House of Representatives a couple of years ago. And what the Equality Act does is that it bans discrimination based on sexual orientation and gender identity, I think in 5 areas: in housing, in education, in public accommodations like trains or planes, hotels, nursing homes, in healthcare, and in employment. But it bans discrimination. I think that's one example of a actionable piece of legislation that could be passed. I don't think the U.S. Senate will take it up, and if the U.S. Senate will not take it up in anytime soon. So what that means is that it leaves it back to the states. And what we will see, the same states banning discrimination based off sexual orientation and gender identity, the East Coast, West Coast, and the upper parts of the Midwest, leaving the vast majority of the country legal for discriminating against LGBTQ Americans in different settings.
Thank you so much. So this next one, I am anticipating you all want to answer this question. So maybe you can do rock, paper, scissors or something to figure this out. But the question is, how might we better use innovative analytic techniques, such as regression discontinuity, to better assess the impact of non-health policies or policy fears on health outcomes? Some examples are immigration policy and health outcomes, LGBTQ bills, et cetera. Thanks for the question. It's a great question. All right, who wants to go first?
Jeremy.
Jeremy.
Let's go in order.
The only thing I'll say is that if you want to say, if we implement this policy or change this rule, this is what we expect to happen, you need to have a strategy that is not confounded by other things. So just comparing 2 groups doesn't really tell you what would happen if you changed the status of one of the groups to the other one. So techniques that are intending and designed to do a better job of really saying what would happen if we change this for this group of people are important and have been used and are continuing to be used in lots of settings, and this would be yet another one.
Fantastic.
I love this question.
I knew you would.
I'm a data nerd, and so I rely on difference and differences and regression discontinuity, and I encourage folks to use high quality evidence for timely policy issues. We need folks to use the best available data that we have right now to answer those very important health policy questions. And if you are unfamiliar with these different methods, then consider a PhD or MPH in health policy.
So I actually don't think it's a methods. We don't need new methods, I think, personally. I think what we really need, where the push needs to be, is getting researchers and policymakers and decision makers and providers to talk earlier. So, as an economist, right, scarce resources, there is probably always a way to design some intervention in a way that we can get a good control group or a good comparison group. But often it's not necessarily considered early on because, policymakers are excellent in making policy. They're not also excellent economists in most ways, or just, any kind of health policy researcher. And so I think if we can get in the room earlier, start those partnerships earlier, that's when we can start really impacting change.
If I could just chime in one more time.
Yes,
I'm
please.
so sorry.
Please, no,
I'm reflecting on this morning's keynote on clinical trials, and we rarely do randomized controlled trials in public policy, in health policy. So we have to rely on these tools that where we can rely on publicly available data or some of the data that we're collecting and try to use creative statistics and econometric methods. So it's important because we're just not going to randomize folks to different policies.
Absolutely. I'm going to go back to you, Adrian. You mentioned partnership and how important it is to establish those early on. So it's not just a matter of showing them the published paper, but really developing relationships. And so one of the questions here is about mobilizing voters and lay audiences. I would add community partners into that. What are some really great strategies for being more informed about what's going on with our community partners and sort of the general public, and how they can get involved in social policy? And I would extend that to, say, research to advance health equity.
Super excellent question. I think a lot about it. I do not have the solution. I think I think it's one of outreach is my current thought, right? Like have a group where you have policymakers in the room with researchers, you have people presenting that are across the gambit, right? You have researcher on stage, and then you have a policymaker, and then you have a provider. I think as much as we can create those environments where there is crossover, where you get lay people, where you get just kind of, yeah.
Fantastic.
That's the number.
So, Gilbert, back to you. In your presentation, you talked about some of the gains of marriage equality were primarily focused among men. So why not women?
This is a good question, and one that I'm still trying to tease out. So whoever asked this question, I'd love to hear your thoughts. I think some of this is probably driven through some biases and benefits that men generally have in employment and discrimination based off sex. We know that men are generally paid higher than women, and probably have better health benefits through employers than women if they're less likely to get promotions or jobs. So I think, and what we do know in the data is that 2 men tend to make a lot more money than 2 women. And so some of this, I think, is through the employer mechanism, and there could also be some discrimination if Roger, for instance, said, hey, can I add Bob to my employer health plan? That might be a very different experience if Jane said, can I add Sarah to my health plan? So I think there's some sex-based discrimination that may limit the role and the benefits of marriage equality for women.
Interesting.
I'm still teasing this out. Yeah, I don't think we know yet.
Thank you. And a follow-up question to that was, is there a role for telehealth here? And I actually think it could apply to any of the groups we've talked about today, whether it's undocumented individuals or individuals in the prison system. To what extent might telehealth, that technology, address some of these things, and what are the barriers?
Absolutely, yes. So telehealth is extremely important now because we know that it's hard finding an LGBTQ affirming mental health provider, for instance. But now with mental telehealth, you can find a provider through apps, through an online system. And what we're learning about gender affirming care for trans populations, including transgender youth, and states where they may be banning access to gender-affirming care for teenagers, for instance, in Arkansas, we're seeing more folks from Boston, from New York, from California, providing telehealth services for our gender minority patients in these states because they are being banned. Now, the issue will be state laws and state regulations with telehealth and whether payment continues after public health emergencies from the pandemic.
Thank you. Jeremy.
So I think there are many circumstances where telehealth or apps are very useful for expanding access. So if you think about rural health, if you think about people accessing the type of care that's best for them, if it's not locally available, those are areas where it's going to have immense benefits. To the extent that people who are very poor may have less access to the internet or to devices or to these services, it can actually widen these sorts of disparities. And so I think we saw some of this with school closures and online teaching and those sorts of things, and the differential effectiveness across sort of socioeconomic status. So I think that there is a challenge which is addressable, which is how do you make sure that those sort of access extending services that themselves are equitably sort of enabled for folks who need the most.
Absolutely.
I just want to echo that. So I'm working with a provider who is trying to connect individuals who are leaving incarceration with social programs. And about 50% of the population that is engaging basically engages first because they get, the firm is offering them free internet. So that is like a hugely valuable service to them. They don't necessarily click on the Medicaid link, they want the free internet. And that is in and of itself a conduit into those social programs, into these telehealth, right, additional pieces. And so I think thinking about how to expand access on that margin is really important.
Thanks so much. Okay, this is the last question, and so I'm sort of rapid cycle for each of you. It's an excellent question that says, what advice would you give to trainees for getting our work to the people who have the power to create and change policy? I'll start with you, Adrienne, and then come back to Jared.
Well, so I'm all about that provider angle. So I think That's the best way to do it, is actually get boots on the ground, right? Go work with the provider, show up for the day, even show up. I mean, something that I encourage myself to do all the time is go to a clinic, shadow a doctor, and actually see what's happening on a daily basis to the average individual. I think it's really easy to get stuck in our ivory tower, potentially, or whatever bubble we're in, but just to make very conscious efforts to break out of that.
Can you repeat the question just one more time?
Absolutely. So the question is for trainees who want to get their work out there and known to people who actually have power to create change, how do they do it?
Great question. And so I often advise trainees that right now your job is your training program, whether you're a student or a resident or a fellow, that's your full-time job. And you may feel powerless at this during this time, feeling like your work may not be making a change fast enough. But time will come. And so continue your work. And once you start your careers and then when you're running full speed, that's when you'll have opportunities to definitely make a big difference. You know, the other way that, the other way I like to engage in policy is through Twitter, or through writing perspective pieces or viewpoints in medical journals, or op-eds in newspapers, because that is a way of getting your voice and your perspective out there to an audience that may not be thinking about an issue that is important to you.
So I would agree with all that's been said, and I would add, try to identify faculty who are engaged and connected in, and also who are enthusiastic about promoting trainees and students. In our COVID work, we had multiple of our trainees briefing state policymakers or people who are in charge of the state prison system, and we're sort of putting them up in front, presenting the work that they led. And so that's not unique to the work that we're doing. There's a lot of faculty here who are engaged with a lot of different groups, and work with them. They'll help kind of get you along that way, just like getting you along the way with research.
Great. Please join me in thanking all of our amazing panelists for their